Welcome to AETCM, the Emergency Medicine Channel. Presenting the case of a 23-year-old male who came to ER with complaints of incomplete voiding of urine and finding a difficulty to micturate since the last 3 hours, and along with lower abdominal pain. On initial 10-second assessment, the patient was conscious oriented. He was talking in full complete sentences, and the airway it was patent. There was no pooling of secretions, gurgling sounds was stridor. Breathing wise, the saturation was 99% room air, chest was clear, no presence of any added sounds, and respiratory rate was 16 per minute. And circulation, the BP was 130/70 millimeters of mercury with a pulse rate of 94 per minute and a respiratory rate of 18 per minute. And disability wise, GCS was E4, E5, M6 with pupils equal and reactive 2 millimeters. And exposure wise, there was no presence of any rashes. The temperature was 96.7 degree Fahrenheit and GRBS was 96. So we had also asked the pain score of the patient at that point. The pain score was 7 out of 10. So he was complaining of a complete difficulty to void the urine. So that was the main presentation at present. He also had an outside USG report with him, which showed that there was presence of already a calculus in the region of the prostatic urethra. So initially the bladder was packable. So since he was in pain and in distress, so we tried to drain the urine by putting a Foley's catheterization, and the clear urine of about 550 ml was drained out. And following which he had felt relief. And the pain score had reduced to 2. Following which. And after that, we had taken a sample history. The sample history, the patient was 23-year-old male. He had a known case of a right VUJ cal in the of 8 mm size, and he came to ER with complaints of incomplete voiding of urine, along with increased frequency of micturition, along with lower abdominal pain and pain during micturition. So that was the complaints with which he presented to ER since last 3 hours. There is no history of any hematuria associated, and there is no history of any fever, or there is no history of any pus or discharge in the urine.
Hematuria, I mean, before we state the term hematuria, it can be microscopic as well. So he might not be able to see as well. So you cannot say it is hematuria. Discoloration, red discoloration wasn't there. That would be the best possible term to be used.
Yeah, so there is no presence of any discoloration, reddish discoloration in the urine. And there is no presence of a previous history of any trauma to the genital region or in the abdomen. And following which we had asked him the allergic history. He was not allergic to any drugs, and the medication history, he was not on any regular medications. So the past history, he gives a history that last month he was diagnosed to have a right vesicoureteral junction calculi of 8 millimeters with no presence of any hydroureterin at that time. So he was managed conservatively at that time, and now he has presented with these symptoms. And the last meal was taken 2 hours back. So following which we had done also as adjunct, we had also done a point of care, the blood counts, and we had done also a venous blood gas. So in the point of care counts, the total counts was 7,600 with a CRP of 3 and a hemoglobin of 12. And the venous blood gas wise, there was no presence of any acidosis, and the creatinine was 0.9. So at that point, and following which we had moved on to again repeat an ultrasound scan from our side, and following which there was presence of a calculi in the bladder. So it was the calculi following the catheterization
has migrated to the
bladder. And following which we had asked for a urology consult at that point, and following which they had seen the patient and had taken for a procedure which is a cystolithopaxy. So that's the patient was taken for a particular procedure. That procedure involves they insert the cystoscope through the urethra, following which they break the calculi and they extract the fragments. The patient went through that procedure and he was relieved also.
So basically we have a case of renal calculi, nephrolithiasis.
Yes.
All right. So when it comes to this case, let's discuss a little bit of the pathophysiology involved in renal calculi. What are the most, what causes renal calculi? How does it form?
So renal calculi is usually due to the supersaturation of the dissolved salts which are present in the.
All right. So there's a solute excess and a decrease in solvent. It can be decrease in solvent and solute excess. So supersaturation. So what are the most common stones?
So stones, almost 80% of the cases it's due to calcium.
Calcium oxalate
or calcium phosphate stones.
Okay.
So that's almost 80% of the cases. In 10% of the cases, it will be due to the struvite stones. It's magnesium ammonium phosphate. So such stones usually they can present as a
staghorn calculi. Mostly they'll be embedded in the renal pelvis itself. Take the shape of them. Right. These are due to any particular reasons?
They'll be accompanied by an infection too. So mostly proven by Proteus or the presence of Klebsiella or Staphylococcus. So usually if such calculi are present, they are usually impenetrable by the antibiotics. So requires urgent treatment for the
urologic intervention will be required. Right. What are the other kind of stones after that?
So other than that, there will be presence of cystine stones. And then another is stones which are induced by intake of drugs. So basically like kinds of anti-HIV medications like Indinavir. Indinavir can also cause this renal calculi.
What is the uniqueness of Indinavir stones?
They are
radiolucent stones.
So they can't be visualized even in a CT or a abdominal radiography.
All right. So as we finish the pathophysiology, let's discuss about the etiology or the common risk factors associated with renal stones, renal calculi. What are the risk factors? Whom would you, what kind of individuals are you going to expect that they're going to have stones?
One factor involves the body, the physiology of the individuals. If patients are obese individuals, they usually have an increased chance of hypercalciuria. So hypercalciuria, even excess salt intake. So that also can cause hypercalciuria and lead to increase.
So as we discussed, there is supersaturation. More of solute will be there. Right. Yes. Next.
So next could be due to the low urine volume, due to reduced fluid intake. So that allows the solutes to supersaturate.
Right.
Next could be due to the increased dietary intake of meat. So meat intake can increase the purine content.
Which would become acidic urine. So acidic urine, what happens? Citrate is overconsumed. So citrate and magnesium deficiency can also lead to stones because citrate helps in the conjugation of the calcium. So when citrate is in less, it allows calcium to supersaturate. So that is one reason for stone formation. Yes, go ahead.
So next one will be the presence of family history. So previous family history is another factor. Insulin resistance. So in insulin resistance also, or in presence of metabolic syndrome, it's mainly due to the presence of ammonia. So there will be due to reduced ammonia, there will be presence of increased altering the pH of the urine. So the acidic pH.
All right.
So again, the acidic pH can lead to the formation of calculi. Such individuals. Presence of gout. So gout can lead to uric acid stones. So hyperuricemia. And the presence of hyperparathyroidism.
So uric acid stones was also there in the list of stones that we missed. Right. Next.
And so again, a bowel surgery or inflammatory bowel disease. So in such individuals, the patient might be dehydrated,
so low urine volume, low solvent. Okay.
So these are they are medications.
What are the common medications? Right. So one you just told, Indinavir sulfate. Next
it could be diuretics. So excessive use of diuretics. Like loop diuretics. Like furosemide. So that can also cause increased stone formation. And
diuresis will cause alkalinized urine, because of which the citrate is not able to act as well. The same thing happens here, because of which there will be calcium precipitation. Right. Next.
So next, other drugs involve the antiviral like acyclovir or even triamterene. So triamterene also, these both are also involved in the formation of
urine. All right. So these are the predisposition or the individuals whom we would suspect, for them to have renal stones. Now, renal calculi, how do they normally present to us?
There's always a classical saying that renal calculi can present as a loin to groin pain.
Loin to
So
groin
loin to
pain,
groin
classically
pain is
called
a
loin to
classical
groin
presentation.
pain.
And usually this pain is usually is a visceral type of pain. So the patient may not be able to particularly localize the pain. So that is what is
Right,
so,
right. It's a hollow viscous organ, ureter. So there is a visceral pain. Right. So there is irritation of the hollow viscous viscera, and then there might be a back pressure to the kidney, which increases the gerotas facius pressure, which would be causing this loin to groin pain. And also we should realize that the loin to groin pain, according to the location of the stone, it can vary. If it is a pelvi-ureteric stone, then it will classically present as a flank pain. If it is a mid-ureter stone, it can be in the lower anterior abdomen, lower quadrant of the anterior abdomen. So it can mimic other pains is what I'm trying to say. And also if it's a distal ureter stone, it can present in the groin region pain. All right. Now, what are the common areas where the stones can obstruct it? Why though? Why these areas? Like as I told, why do these areas have a predisposition?
So usually the stones get dispersed around the uretropelvic junction. So that's one of the areas where uretropelvic junction.
Because there is a imminent constriction as soon as the pelvis ends. 1 centimeter pelvis suddenly constricts to a 2 to 3 mm ureter. Because of which the stone can get obstructed there, right? The next area would be
the pelvic brim.
Pelvic brim.
So that's where the ureter causes of the pelvis and iliac vessels.
Iliac vessels. So
and another area is the uretrovesical junction.
Uretrovesical junction.
So the uretrovesical junction is the most constricted site of the ureter. It's mainly due to the muscular cord of the bladder, which is causing the constriction.
Right.
So these are the various areas where it can get compressed.
Okay. And now you told me about the presentation and tell me about the differential diagnosis. What else should you be expecting?
So in a differential diagnosis, it can be due to vascular cause. So vascular cause, or it can be due to again the genitourinary different various causes.
Right.
So the first one involves the vascular causes involves the five different causes. The first one we should rule out will be anyway an abdomen aortic aneurysm. So an aortic aneurysm or an aortic dissection. So these both we also need to rule out.
Again, they'll have a vague abdominal pain. So you should have this behind your head. You cannot be directly pinpointing and tell that okay, it's a renal calculi without running through these differentials as well, right?
Along with that, there can be presence of a renal artery embolism or a renal vein thrombus and mesenteric ischemia. So these are the various vascular
causes, right?
Renal causes mainly involves pyelonephritis or papillary necrosis, renal cell carcinoma, or renal infarct or renal hemorrhage. So these are the various causes, renal causes. In ureter, it may be usually due to a blood clot.
It can be a clot, it can be a tumor, it can be a stricture as well.
Along with that, bladder basically a tumor or presence of an infection, a cystitis, can also lead to, it can be cause differential. In GI causes, there could be presence of a biliary colic. So biliary colic can also present along that region. And pancreatitis, appendicitis. Appendicitis is one close DD if presence is in the right iliac fossa region. And the inguinal hernia or diverticulitis. So or bowel obstruction can also be present with pain. And gynecological causes also needs to be ruled out.
Very important.
So always in case of females, menstrual history always.
Any reproductive age group of female who is presenting to us, we should ask for their last menstrual period. And if you are suspicious of it, you should definitely get a UPT or a beta HCG.
So ectopic pregnancy is one of the close DD. Along with that, pelvic inflammatory disease or tubo-ovarian abscess. So these are the next close DD or ovarian cyst or ovarian torsion. So these can also be close differential with or possibility of endometriosis.
Good. What are the lab investigations that you would go for? Is there any, if any?
Lab, mainly we look for the counts, blood counts. Look for if there is a presence of any infection. We do look for the urine routine. So that to look for the presence of any pus cells or presence of RBCs. So
RBC, hematuria.
And presence of cast.
What is hematuria? More than
3. More than 3 RBCs.
2 to 3 RBC per hyper field.
So these are the various blood tests we do. Otherwise, we can do for radiological imaging.
All right. So when it comes to blood tests, in case you mentioned in your VBG that the creatinine was normal. So, how is creatinine important? Do all renal calculi can they present with the deranged RFTs?
No, not
No.
necessarily.
Why though?
Because the other unaffected kidney can compensate for the functions of the
Other kidney. Almost 185% it can go up to the functioning kidney with the non-functioning kidney can take up their function and go up to 185% for almost 1 month. So if the obstruction has been there for more than 1 month, then it can create RFT derangement. But if at all it's an acute cause, if at all the creat is deranged, what would that indicate?
Usually creat derangement indicates the patient could be having a solitary kidney.
Solitary kidney.
Or
Right.
patient could be having underlying kidney disease.
Kidney disease. Yes.
So,
Yes. Yes.
these are the possibilities.
Right.
So along with this, we do the various radiological investigations. Investigations mainly involve the USG or NCCT. So non-contrast CT, we can exactly identify the locations of the stone and also look for the hydroureteric nephrosis underlying. If it's present,
Okay.
can also be identified.
So say you did the CT and you came to know that the renal calculi size would be like 8 mm or say 4 mm or say 5 to 6 mm. How can you counsel the patient regarding the whether it will pass or whether it is going to cause a problem?
Usually a stone which is less than 5 to 6 mm can spontaneously pass through the
So they say that for stones less than 5 mm in size, as you said, around 90% of the stones will pass within the next 4 weeks, in the next 4 months. All right. When it comes to stone sizes of 5 to 7 mm, then there is a 60% chance that it will pass. When it is more than 7 mm, the percentage would reduce to around 39%. All right. So I'm just saying to counsel the relatives or the patient himself, right? Now, in case they come with severe pain, because this is going to cause a lot of issues for the patient, you know how they present to us. So, in case the patient presents to us with severe pain, what are the medications that you would go to?
The ideal analgesic of choice would be to choose an NSAID. NSAID always has it acts against the prostaglandin synthesis. So that can be ideally used. Can be given a ketorolac or can be given ibuprofen. So that can be given. So that's one of the options. We can use opioids.
Beware if there is any RFT derangement, just look out for that.
Yes.
All right.
And if patient is
and also if they are allergic to NSAID, so that history also should be taken before you administer. Right. Next, in
case of opioids, we can use opioids, but we should always use in caution because we should always add an antiemetic along with it.
As well, because the patient themselves will be mostly vomiting because of renal colic. The patient might have vomiting, so this might trigger more vomiting. Right. All right. Okay.
So these are the usual pain medications which we give.
That we go to.
Yes.
Okay.
And following which there's a provision for a medical expulsion.
Medical expulsion therapy can also be tried.
So in such individuals, we usually give a pain medication. Along with that, we give an alpha blocker. So
an alpha blocker.
Like tamsulosin.
Tamsulosin
Can be given 0.4 mg per hour. Can be given for daily dose.
What does tamsulosin do? How does it act?
Tamsulosin is a smooth muscle. It acts as a relaxant. So
all right.
Basically, it relaxes the area of the prostatic urethra region
and helps in passing
of the stones.
All right.
Along with that, steroids are generally not indicated, and so along with that, we give the pain medication. So this involves the therapy,
the management of such patients. Yes. All right. So in case if you have a renal calculi patient presenting to us, what do you think are the points that you should keep in mind if they have to get an inpatient admission or not?
Yeah. So there are some absolute and relative factors mainly. So in absolute indication for admission is usually in patients with renal calculi who have an intractable pain or vomiting. Even despite giving all pain medications, he's not improving. Or if patient is in a urosepsis. So in a urosepsis, the primary source could be the obstruction due to the Caliculi. So that's why we need to.
And as you said, if it's a white stone, there's definitely an infection possible. So
yes.
you'll have to start IV.
IV. So next one could be a single or a transplant kidney. So there are those individuals or in patients with hypercalcemic crisis underlying, and these are advanced age or with multiple comas.
Okay.
Such individuals must be absolutely they must be admitted. Relative is usually if patient just has a fever associated. And so even in a solitary kidney without any presence of obstruction, if there is obstruction, you must be admitted. Without obstruction, can be it's a relative indication.
Relative indication.
And along with that, the patient if he's having a like if stone is unlikely to pass, if it's a large stone, just above the pelvic. So such stones also we can just it's relatively.
All right. What are the antibiotics that you might start?
Antibiotics usually in such individuals we can.
If at all there is a UTI, what are you going to start?
UTI we can start with different antibiotics mainly involves ciprofloxacin. Ciprofloxacin we can be given or even we can give levofloxacin. Ciprofloxacin usually involves 500 mg per oral twice daily. It's for 10 to 14 days. Or we can give levoflox also even 500 mg per oral once a day.
Once daily.
Once daily for 10 to 14 days.
Okay.
And you can also try cefpodoxime. Cefpodoxime is another antibiotic. It can be given 200 mg per twice a day for 10 to 14 days.
All right.
So this is the way to say it.
Anything else that you want to add? That's it.